Hello and welcome back to Phlebology's Meet the Authors series. I'm Sherry Scoville. I am a vascular surgeon and a phlebologist and your host today. We are really delighted to be talking with Dr. Tony Pihlaja from Oulu University Hospital in Finland, and he can correct me if I got that incorrect. He's the first author of the paper entitled Subalcer Foam Sclerotherapy in Patients with Venous Ulceration, a randomized controlled trial. This was published in Phlebology at the end of 2024. We welcome you, and we're so delighted to have you here.
Thank you, Dr. Scoville, and thank you for the kind introduction and for the possibility to give a little conversation about the trial we have published.
Wonderful. So why don't we start with you telling us a little bit about how you conceptualized this trial and how did you come up with the idea?
Yes, so in this trial, we really wanted to put the subalcer foam sclerotherapy in action in randomized controlled trial setting. I think there has been some discussion in past year in international conferences regarding this technique. However, the level of evidence is currently quite low, and this is, of course, something we came up with. And of course, one of our inspiration was the EVER trial and the early intervention benefits. And we wanted to take those even further to evaluate the immediate subalcer foam sclerotherapy in patients with venous leg ulceration.
I totally agree with you that early intervention is so important in these patients. I have a question though. So all of your patients had venous ulcerations and superficial venous reflux. And in your study, you really chose to focus first on treating that peri-ulcerative venous plexus. So if I understand you correctly, after you achieved your primary outcome measure of ulcer area reduction at 4 weeks, um, then did you treat the superficial venous insufficiency with ablation and foam sclerotherapy of the tributaries? And why did you choose to treat that peri-ulcer plexus first and not the superficial venous insufficiency?
Yes, so in this trial, we had a great opportunity to perform foam sclerotherapy in the very first visit to venous outpatient clinic. And the subalcer foam sclerotherapy is something that we were really keen on to find the effect of subalcer treatment. How does that affect the subalcer area, and how does it affect the ulcer reduction? And ultimately, we think that the approach in superficial insufficiency should combine also the truncal ablation. And that's why after 4 weeks, after we got the information, how does the subalcer foam sclerotherapy alone affect the ulcer area, we really wanted to treat the patients in best possible way in both groups.
Fantastic. So getting them in early and treating them, did you say at the first visit?
Yes, so in our country, in Finland, there is good public health care, and we don't have to work with reimbursement. So we are really able to provide the foam sclerotherapy to patients in the very first visit to vascular outpatient clinic.
Bringing us back to that early intervention is important, right?
Yes.
Your technique is very interesting, and I'm going to just show the figure that you have in your paper. Could you please talk a little bit about the employing multiple cannula? I know you said it was very important to at least have some cannula distal to the ulcer, but can you share your thoughts on your technique?
Yes, perfect. So what we can see here is actually subalcer foam sclerotherapy treatment in action. So we have some recommendations when doing this technique, and we prefer always using ultrasound. Pick the veins you can cannulate with ultrasound. And usually by doing this, you can go a bit distal to ulcer. And of course, as we all know, the skin quality is often the worst right next to ulcer. There is inflammation, there is induration, but if you can go just a bit distal, you can usually get better skin quality for injections and hopefully get a reduce in risk for iatrogenic infections. So we prefer picking tributaries around or distal to ulcer, and of course we will check that actually those tributaries or distal truncal veins are leading to subalcer plexus, because that's the area where we want the foam sclerosant to be applied.
And then tell me a little bit about these proximal cannula we see.
Yes, so in this particular picture, we can see also cannulas proximal to ulcer, and that's because we also think that in addition to treat the subalcer plexus, the reflux leading to ulcer area should be covered so that we can reduce like the venous inflow to ulcer, and this can be performed with foam sclerotherapy as well. So we like to cover the reflux in the calf area as vast as possible.
And what size are these cannula?
The blue ones are 22 and the other ones are 20 gauge.
Awesome.
Yes, and they were all applied under ultrasound guidance.
Wonderful. One of the things I'm always typically concerned about after foam sclerotherapy, especially in this area, is DVT. Did you see any DVT in your study, and were there any measures that you could take to prevent DVT in your patients?
Yes, I absolutely share this concern with you. But fortunately, we did not meet any deep vein thrombosis in this study. And we have also been conducting and published a retrospective trial with a larger study group. And the result was the same. We did not find any deep vein thrombosis issues. And there are some considerations which I think help in reducing the DVT. First, as we discussed already, when using multiple cannulas, you can usually inject smaller amounts of foam sclerosant per cannula, and probably you can reduce the risk for deep vein contamination. And also, what's of course recommended is to follow the foam distribution with ultrasound while you are injecting. And one of the things we also do, which is not directly related to deep vein thrombosis, but is related with the infection risk issues, is that between the probe and skin, we usually prefer alcohol instead of ultrasound gel. So it like acts as an ultrasound gel to get the visibility for the area. But with these measures, we did not found any deep vein thrombosis events, and we do not have any regular thrombotic prophylaxis after this treatment.
Do you ambulate your patients right after you put on the compression stocking?
Yes, so after the operation, after the ulcer debridement if required, the compression is applied, and the patients are advised to walk 20 to 30 minutes before longer sitting times. And also, as I mentioned, we don't have any regular thrombotic prophylaxis, but of course, if the patient is prescribed for antithrombotic medicine, those will be ongoing throughout the treatment and the post-operative phase. So we don't, of course, withdraw those either.
Wonderful. So this has been extremely helpful. Do you have any overall take-home message from your trial, and what can we expect from you next?
Yes, so based on this trial we conducted and the retrospective data we have also published earlier, we can see that the subalcer foam sclerotherapy seems very promising treatment modality when we are dealing with the endovenous approaches to treat the superficial insufficiency. So, and actually, what we are currently ongoing as a trial is a nationwide, multi-center, randomized controlled trial with the subalcer foam sclerotherapy technique. And in this trial, we are evaluating how does the subalcer foam sclerotherapy affect on time to ulcer healing.
Wonderful. We definitely look forward to that. And it's been such a pleasure to have you on Meet the Authors. We thank you so much for coming on.
Thank you.
You're welcome. And until next time.
Thank you, Dr. Scoville, and pleasure to meet you.